Hello, and welcome to the Center for Health Design's Evidence-Based Design Journal Club. Thanks for joining us. I'm Alan Card, a research associate with the Center for Health Design, and I'll be your host for today's webinar. Before we begin, I'd like to thank the editors of the Journal of Interior Design and Wiley Online Library for providing special access to the article we'll be reviewing today. The purpose of the Evidence-Based Design Journal Club is to engage the healthcare design community in dialogue regarding important research to help us better understand the links between the built environment and health-related outcomes, and to apply that understanding in the real world. I'd now like to introduce you to the authors of the article we're discussing today, Lisa Sundial Platt and Sheela Bosch. Lisa Sundial Platt is the CEO and founder of UMen Systems, LLC. Her firm is a human experience research and innovation management solution provider that works with U.S. and international health, wellness, and continuing care organizations seeking to implement transformational change. Her expertise is in working with cross-functional quality and performance improvement teams to facilitate process optimization and to increase product and service delivery efficiency, safety, and outcome reliability. Lisa has served as a research primary investigator and authored several publications related to the impact of systems on human health and well-being. She holds a Master's of Science in Industrial Organizational Psychology and is nearing completion of her doctorate in Systems Science with a Health Systems Engineering focus at SUNY Binghamton. Her research concentration is on human factors and population health systems resilience. She is also an ASQ Certified Sigma Black Belt, certified in lean and statistical process control of healthcare services, service and product delivery processes. Her professional background includes over 25 years of tenure in the field of organizational strategy, human development, and environmental planning and sustainability management. She currently holds professional licenses with the states of Tennessee and Florida, boards of architecture, engineering, and design regulation, evidence-based design accreditation and certification with the Center for Health Design, and is a U.S. Green Building Council LEED certified professional for building design and construction. Sheela Bosch, assistant professor in the Department of Interior Design, is an advocate for human-centered design research. In 2014, Sheela was named top researcher by Healthcare Design Magazine's HCD 10 Awards, and she is dedicated to improving the planning and design of both healthcare and learning environments. A thought leader in the field of evidence-based design, Sheela regularly speaks at national scholarly and trade conferences and has authored numerous peer-reviewed and non-peer-reviewed articles. Sheela recently served on the National Academy of Medicine's Scientific Advisory Panel for the Evidence Base on Patient and Family Engaged Care, and she serves as an ad hoc reviewer for several peer-reviewed publications, such as the Health Environments Research and Design Journal and the Journal of Interior Design. Having earned her PhD from the Georgia Institute of Technology College of Architecture, Sheela also holds an MS and a BS from the University of Tennessee. Thanks to both of you for joining us today.
Thank you, Alan. Wow, that was a mouthful.
As I mentioned, we're hosting this event specifically to identify the everyday practical applications of research findings in a published article. Today's featured article, Toward a Framework for Designing Person-Centered Mental Health Interiors for Veterans, from the Journal of Interior Design. On today's call, we'll have an active discussion about different key factors in your study. Sorry, I'm skipping ahead by mistake. And at this point, if you two would please take it away.
Thank you, Alan. It's so good to be here. I'm a big fan of the Journal Club. So let me tell you a little bit about this study and how it sort of got started. When I was working with Gresham Smith and Partners, they were working with Guidon Design to do a complete renovation of both an inpatient acute mental health unit as well as outpatient unit. And so being, concerned about human-centered design and caring for the veterans, they really wanted to do sort of an evidence-based design kind of project around this renovation opportunity. So because of Lisa's expertise and also her experience, vast experience working with the VA, we brought her on board. And what we did was, well, I'll tell you more about it, but we did this study with 3 different case studies to sort of put together this framework. What we found was that, in fact, there was really no good framework for how to sort of compile information and look at the research in terms of design for mental health. Oh, I'm trying to click forward, but it is not letting me click. So, oh, there, okay, perfect. Well, as we know, mental health is obviously a big problem, not just for veterans, but for the adult population throughout the U.S. And there really is a little bit of a disconnect between some of the design guidelines that we see and staff perceptions of what they need. And we felt like we had a lot to learn from VA pioneers who were working in the mental health arena. And as I mentioned, we really just wanted to develop this framework based on the good work that was being done and the literature that existed to improve the operational practices, design, planning for mental health facilities for veterans into the future. So Lisa, I'll let you jump in with methods here.
So thanks, Sheila, and thank you for the lovely intro, Alan. Appreciate being here. So just to dovetail off of what Sheila talked about in terms of our approach, we'll discuss a little bit about the methods we took in developing this research. It's worth noting that the VAs that are highlighted in this research were those that already either had process, cultural, or capital improvement quality projects underway. Due to the nature that the site-specific data that we used from them fell under the umbrella of quality improvement, although filing an IRB was discussed and in some instances actually commenced with all 3, it was determined by each VA that this particular stage of the research did not require filing an IRB. So in terms of the overview, in order to knit together a framework for this effort that offered opportunities for connectivity and continuity, the research team conducted a very comprehensive literature review. This included many peer-reviewed studies, as we could find, that were relevant to developing this research, but due to the relative lack of empirical research into designing mental health environments, specifically for veteran populations, we also, as Sheila indicated, included a fair amount of valid resources that offered viable practices for designing VA mental health spaces. And this material was largely gleaned from the VA resource guide cited in the study. So as Alan had articulated in the introduction, my background is actually in human factors. And because I had already been working with VA New Jersey on a quality improvement effort and they had opted into the study, we also employed the use of human factors data generated from that particular quality improvement effort that centered around 2 of their acute inpatient mental health environments on each campus. And this included not just ergonomic and safety criteria related to the design elements of the physical environment, but also looked at elements such as working memory for staff, such as interruptions to work, and locus of control or situational control for veterans, which were addressed by introduction of some small seating areas outside of the day room, and increased vehicles for signal detection from both physical and electronic methods that increase potential for safety systems resiliency. So again, although the sample of VAs that opted into this effort were something of a convenient sample due to the presence of their current quality and expansion work that was related to this research effort, there was actually an intent to their selection that focused on their observable commitment to patient-centered care. And those included the VA Ann Arbor, which was the first VA site to ever achieve Plaintree silver-tiered recognition status. And for those of you who aren't familiar with Plaintree, they're an international patient advocacy organization that was working with VA Ann Arbor at the time. VA New Jersey Healthcare Systems, East Orange and Lyons campus. Their East Orange campus is actually the home of one of the first ever Center for Health Design Pebble project. It's their pharmacy project. And the VA Tennessee Valley Health System, which is the first site in the southeastern part of the United States region to implement the Office of Patient-Centered Care and Cultural Transformation, Veteran-Centered Care Planning Cycle, and the OPCC NCT, which is a bit of a mouthful, is actually a central VA agency that is charged with integrating veteran-centered care at VAs. So now we'll talk a little bit about what the process of data collection looked like from these three related in context but different quality improvement efforts. So this is one of those examples that have been alluded to in the study that is a traceability tool that we borrowed from systems science and systems engineering to help the staff and veterans who were former patients of VA New Jersey AIMH prioritize both the technical performance requirements, or in other words, the whys, and the design-dependent parameters, in other words, the whats, perceived as critical requirements for the redesigned mental health units. It's basically a matrix that's created through multi-voting and ranking that allows for relevant themes in human-centered design to be parsed and categorized and then linked to purposeful environmental elements that achieve those criteria. It also allows for the development of quantitative data that can be used as a baseline and for design goodness of fit benchmarking purposes. And for a human factors engineer like me, generating relevant metrics was a very important part of being able for us to continue to validate the framework resulting from this effort. We also talked a bit about engineering for safety and designing for human-centered care during this effort. There are, as we know, often things that are clinged to in an EOC design because of them being perceived as safety measures, which, as probably most of us know, are not actually engineered to perform the way staff is hoping that they will, which could actually increase the probability of risk. So we talked a bit about contextualizing the critical incidences of risk in terms of probability of occurrence and time frame of reference, but we can discuss that more in the Q&A if that's of interest. So the next site we'll discuss is Tennessee Valley Health System. For TVHS, their 4 North Design Development project that Sheila referenced earlier, the architects of record who were Guidon Design and Gresham Smith and Partners here in Nashville brought Sheila and I in to observe and record an ideation and charrette session facilitated by Deborah Wingler of Healing Design Integration. And although this session was a bit more focused on the creative collaboration around EOC design, it also provided a great vehicle for us to be able to get patient-centered care themes parsed into functional-based composite criteria, which ended up being the restore veterans' dignity and well-being in a place of refuge, returning veterans to normal life, and advocating for veterans' needs throughout the care continuum. So with that, I'm going to go ahead and pass this back to Sheila.
All right. So just to share a little bit about our findings, if someone will advance that slide for me, I don't know why I'm having issues. Perfect, thank you. So yeah, what we came up with was this framework that I just remember myself using the acronym SPICE with 2 P's. So we are looking at design strategies regarding sustainability, and particularly more the indoor environmental quality piece, acoustics, thermal comfort, those kinds of things, good indoor air quality. One of the P's is personalized, and there is some literature and best practices around allowing the veterans and patients to personalize their environments. Protect is the 3rd category. Of course, probably number 1 is to protect the veterans, the patients, and the staff. The I is to involve, and there, I think, is a lot to be said for involving veterans as well as staff in the planning and the design process. The C is for comfort. Of course, these environments, and there's literature around, should be welcoming and comforting. And the E is to engage. And when we talk about engage, we're also talking about disengage. People should have the opportunity to have control over how much access people have to them at any given time. And this is not only engage between the veterans on a unit, but it would also refer to engagement between the veterans and the clinical staff working there as well. Next slide, please. So what we're hoping is that this information, and we've compiled some design strategies under each of these categories, and we really hope that it will help get the conversation going early in that planning and design process among these various team members to be sure that all of these particular categories are being addressed in each project as it moves forward. Next, please. All right, next, please. Okay, so here, this is, obviously you can't read it here, but this is just a small snippet of the table in the paper, which hopefully you've all seen, where we have organized design strategies according to those 6 different categories in the framework. We did indicate whether the design strategy or recommendation was based on research, albeit sometimes very small amount of research, or whether it is a best practice consideration. And I think we can talk more about some of those specifically also in the Q&A. Next, please. So we do realize that this has a number of limitations, and I'll let you chime in, Lisa. We did obviously only include 3 case studies. We know that there are other VAs doing great work. And because of the different nature of what it was that each of these sites were doing, we took a little bit of a different approach for each one in order to glean the data from them in order to understand how best to design mental health facilities. We do recognize that the generalizability to other settings outside of these 3 case studies is probably limited, and is also very limited in terms of whether or not we could generalize our findings and recommendations to a non-veteran population. And we'd like to see that, applied in that way. Next.
So
go ahead, Lisa.
In terms of, sure. So just to dovetail off of what Sheela said in terms of the generalizability, one of the things that we're actually hoping that we have the opportunity in the near future to expand on this research for the purposes of validating the framework across the continuum of mental health settings and to increase the potential for generalizability is to gather more specific and focused data that are both objective and quantitative in nature. So we're hoping that these future efforts allow us to better direct the specificity of our data collection to focus on the composite criteria developed in the framework, and that this data collection affords us also the ability to collect, as I said, quantitative numerical metrics where we can potentially gen up some predictive analytics that are linked to systems performance and hopefully human behavioral outcomes. Because at the moment, as we've discussed in introducing this research, based on our literature search, there really is not readily available information, especially that which is objective and quantitatively based, that links design interventions in acute inpatient mental health settings to actual human behavioral response outcomes. So we're hoping that this framework might provide a pathway for developing that. And with that, it concludes our presentation, and I'm going to go ahead and hand this back to Alan.
Thank you very much. That's fantastic. There we go. Overshot. This event is brought to you by the Center for Health Design. Thanks again to the Journal of Interior Design and Wiley Online Library for providing special access to the article. And special thanks to today's sponsor, Steelcase Health. And now it's your turn to ask questions of the authors. Please feel free to type in any questions you may have, and we'll try to get them answered. All right. Well, I will start then. There's some controversy in the literature about the idea of open versus closed nursing stations, both with regard to which is actually safer and to how they affect patients' well-being. Could you talk a little bit about this and what led you to come down in favor of the open nursing stations?
Well, let me just, you are hitting the nail on the head. When I toured for North for the first time in Tennessee Valley Health System, we were walking around and she was showing you the old space, pre-renovation, and one of the nurses came up to her and he said, "You're not still thinking of doing open nurse stations, are you?" Because I've been attacked 3 times, and I don't approve of that at all. But in fact, there's not a lot of good hard evidence yet. But what is interesting is probably there are as many people injured, as many violent kinds of aggressive acts on medical, surgical, and other critical care kinds of environments than there are in mental and behavioral health environments. And the idea behind having this open care team station is really to be more human scale. You don't have that us versus them kind of barrier, and it's really intended to promote informal interaction and dialogue and the development of trust between the clinicians and the veterans. And I think there's a lot to be said for that. And Lisa, I know you have some additional information too and insight about that as well.
Sure, yeah, I think Sheela raises some really relevant points in terms of perceptions. I think one of the things that, again, it's a burgeoning area of study, but there are some compelling studies that actually speak to this. I think it's the Andes and Chatel study that is cited in this particular journal article, that if you are basically visually accessible to patients, you're going to be perceived as available, even if you're working. So therefore, having a dedicated staff work areas that protect their visual access from staff working on tasks where concentration is key is important, while still providing ways, often electronic, for staff to have direct visual access. And the other important thing, I talked about engineering for safety quite a bit, since that's my area. Plexiglass, which is often the barrier of choice that goes up on these nursing stations, an 1/8-inch thick piece of plexi breaks at 18,000 pounds per square inch. Human bone breaks at 19,000 pounds. So coming through a piece of plexi is me on a bad day with a chair. And although I'm progeny of worthy Vikings, I'm also not a former soldier that's trained in hand-to-hand combat. So again, it's important to also understand sometimes the barriers that we set up for safety simply are not engineered as that are appropriate. And for that reason could cause more risk rather than preventing it.
And what the VA Ann Arbor told us is that the staff were a little bit hesitant at first to embrace this open care team station model, but then they all worked together like, okay, how can we make this safe? And that, you can do that through having various kind of depths on the counter on the work area. They did things like, tethering the chairs to the workstation area so that they could not be used as projectiles, and secured the computers and that sort of thing. And to the best of my knowledge, the staff feel very safe in that open work environment.
Great. A follow-up question from one of our listeners is, are you aware of any data that would guide an open station in non-lockdown areas versus those inpatient units that are locked down?
So again, I'm just going to go, I will say the Andes and Chatel study was probably the most direct study that we found that specifically referenced open stations that could be appropriate through a variety of mental health or behavioral health settings. And specifically that dealt with engagement and in work interruptions. There were also some of the studies, and apologies for not remembering it right now, that discussed the disculturation of veterans in inpatient settings that could be used as good empirical data for demonstrating the effectiveness of going with an open station for therapeutic reasons. I have to say, and I'll let Sheela speak to this, there is still a lot of opportunity for improvement to study the efficacy of open stations, and especially in mental health environments. There has not been a great deal of opportunity. First of all, it's very hard to do research and find people who are willing to let you do research in mental health environments, much less study the long-term effect of open nursing stations, or open clinical workstations. So that is definitely something to consider. Sheela, anything you want to add to that?
No, not really. I think you've covered it well.
Okay. We've got a couple of our earlier questions were on what would you say really are the main takeaways, the main findings from this study?
So I think it's important, and we did our best to try to cite this in the limitations of the study. This research is really very nascent in its execution. It's the outcomes of the study, and I can see some of the questions. The outcomes of the study were really to try to attempt to develop a valid framework. One of the things that we discovered in an early interview with the VA Ann Arbor staff was the very, very difficult process of parsing the data related to design interventions in an inpatient mental health unit in a way that allowed, not even for causation, but any type of correlation of outcomes, especially behavioral outcomes from patients and staff. So that the outcomes that I would say that were resultant from the study was the development of a set of composite criteria that could be used as a companion, and then hopefully looking at ways to develop companion research based on this to allow us to focus in on a specific area, such as the protect or the engage, and see if we can draw down historic data and actual quantitative data from surveys that we would send out to develop some predictive analytics that showed actually some objective outcomes to this research. So again, this is very much the first phase of this, and we're hoping to be able to expand on it. Sheela, do you want to add anything?
Yeah, I just want to add, a practical takeaway from this really is that table. We pulled design recommendations from a number of peer-reviewed and non-peer-reviewed sources, as well as the folks that we interviewed with and interacted with during this process. So I would encourage people to take a look at that table and to actually use that in the planning and design process and consider all those factors in the design.
Great, thank you. Back to the open nursing stations question, always a rich vein to explore. Gary asks, how do you handle HIPAA privacy issues with an open nursing station? It's probably a little bit beyond the scope of your study, but did you happen to see how that was managed in what you were working on?
So that was kind of outside the scope of this particular study, but I can tell you that it always comes up in almost every bit of the work that I do, that often when you're talking about taking down barriers, the HIPAA flag is raised. And again, that's something that seeing environments that have got this mastered, like VA Ann Arbor, and to a large extent VA New Jersey, which has been moving into this, looking at ways to promote privacy of health information in strategic ways. I think having a gradation of space where there's an opportunity to consult with varying levels of privacy is one of those solutions that kind of manifested in the VA New Jersey work, where it looked at things like having smaller ad hoc meeting spaces that were directly adjacent to the clinical work area that were a little bit more private. So, and also specifically private counseling areas where that kind of information could be exchanged in a completely acoustical private area, where that's going to be much more effective than a plexiglass barrier is to having, any kind of verbal exchange to protect patients' privacy. I hope that answered the question.
Well, just to add to that, too, I mean, we have the same HIPAA concerns in a MedSurg unit in the hospital, right? We have to orient the screen so that patients or families aren't able to see that information. And like Lisa said, some of that consultation can be done in a more private setting with good acoustical privacy and visual privacy. So, I don't really see it as being that much bigger of a deal. One of the recommendations in the paper is to provide these smaller spaces where you can have one-on-one, patient-clinician discussions, maybe, or engage involve the family member, just these small spaces, or areas where the staff can work heads down, not distracted by, patients coming up all the time. So it's not everything is open.
Right. And that kind of brings up a broader point, which is, I think, Lisa, you were the one who mentioned earlier that sometimes there's a divergence between both the real and perceived risks in the institution and the real and perceived risk reduction that comes with specific engineered solutions. Can you talk a little bit more about how that played out in your study, what you saw, what kind of feedback informed that insight?
Yeah, absolutely. That's a great insight, Alan. One of the things that manifested oftentimes, and I think those people who are on the call who are designing mental health environments, frequently the subject of safety is usually top of mind to anybody who's participating, and that includes both the staff members that participated in this, and it's also important to indicate there were veterans that participated in all of these quality improvement events as well. So it's very much an important topic for both stakeholder groups. However, one of the things that, and again, this is anecdote, I wouldn't want to say this is a significant occurrence, but one of the things that seems to be a common anecdote is the referencing of safety incidences that are often either well outside the norm of occurrence and sometimes have occurred decades earlier. We had one incident at one of the sites that the staff was very cognizant of the fact that a nurse was injured by a patient, and this incident happened actually back before 1990. So although it was a tragic occurrence and it was still very top of mind for the staff and some of the veterans too, it was important to contextualize that occurrence as being A, an outlier, and B, not is prone to occur now with the safety measures that are in place now, just by code standards for designing mental health environments.
And I'll just add, too, we spoke with Jan Stickler yesterday, and, of course, she's a nurse as well, and she said that she's seeing a lot more attention being paid to this idea of safety, staff safety, as well as patient safety, but a lot of concern around staff safety in critical care environments, not just, mental and behavioral. It's becoming an important topic in all of healthcare design.
Absolutely. A couple of tactical questions that may basically just be right from that table is one is asking about whether artwork throughout the facility in common spaces or private rooms was helpful, and another if soft music playing in the hallway was studied and found to be helpful.
Well, I don't know of specific, research, say, on artwork done in a mental or behavioral health facility, but there is such good, literature in the evidence-based design world on the importance of art as a positive distraction. And what I think was done really well, and Lisa, you've actually seen it in person. I've only seen it in pictures, but the VA Ann Arbor had beautiful artwork, but everything was very safe. Those, the frames could not be ripped apart and used as a weapon in any way. And Lisa, you might want to share more about that as well.
Sure. So again, VA Ann Arbor is really a paragon of people who really got it right, but were very intentional with their design. As Sheela was saying, there was actually ample access to nature-based artwork throughout that facility. There was huge pictures of landscapes that were prevalent in Michigan, which is where they're from, but they used a neoprene frame that was flipped over and silicone sealed to the wall, so it couldn't be used as a ligature point, and also couldn't be ripped off the wall easily and then used as a potential weapon. We did reference one study. I think this is a good question because oftentimes working with either patients or in the VA veterans, there's often one of the things that in an inpatient setting, there's a desire to be able to go outside and connect with nature, and oftentimes in aging visible plants, this is very, very difficult, and especially given the population for safety reasons. So artwork does offer a great opportunity to simulate nature, and again, VA Ann Arbor did this not just through artwork. They have an aquarium in the waiting area that was in direct view of the staff, so and again, behind a security wall, but clear visibility. They also used sky view panels throughout, and interestingly enough, had light columns that were timed to circadian rhythm of the staff to try to help with staff wakefulness, and used a night light in the veterans room that was red, so it didn't disturb the pineal gland. And again, it would be great to do some more research related to that, but we were able to find some research and cite it based on the integration of artwork for simulated nature and the benefit of that. And again, it would be a wonderful opportunity to be able to study the actual objective outcomes of that in future research.
And I will say probably the ideation session in Tennessee, probably the number one thing that the veterans there wanted was access to the outdoors. Unfortunately, the way that facility, is older facility, and it just were unable to find a way to make that happen in a secure way. But I would say access to the outdoors, even more so than artwork, is really high on the veterans' priority list.
Absolutely. Another question is, are semi-private rooms recommended for the VA, and what percentage of semi-private versus private? Knowing David's sign as I do, I suspect very few private. Is that correct?
There were very few private, and interestingly enough, this is a great question because before I became a human factors engineer, I worked in design, and the modus operandi in healthcare was all private rooms, all private rooms. That was certainly voiced by female veterans who are inpatients that participated in this as being something that they would like. There are at the VA sites that were involved in this study. VA Ann Arbor and New Jersey at this time don't have private rooms. However, in hearing from some of the vets, there was some indication of a desire for a roommate, for being able to have some camaraderie during that experience. There was a lot of discussion in the work with the interviews with VA New Jersey, especially, where veterans talked about liking to have a roommate because it was somebody you could talk to that had gone through the same thing you had gone through, or could at the very least identify with it. So again, although that's one of those topics that's always under investigation for a variety of reasons, there doesn't seem to necessarily be a one-size-fits-all, anecdotally speaking, at least in the quality improvement efforts, two of the quality improvement efforts related to this research.
But I will say, too, the ability, though, of the veterans to be able to have more alone, quiet time is really important. And we saw some of the places were able to do that with in-room cameras, and they allow the veterans to lock the door to their room so that other veterans or patients can't just wander in, and so that they have this privacy. But of course, those can be overridden by the staff if there's any concern about safety whatsoever. But there is this important provision of sort of choice and control of whether or not you do want to be, close up speaking with someone, or you really just want to be left alone for a while.
That's really interesting. There were a couple of people who asked about how veterans' mental health patients might differ from the general population of mental health patients, and how the design of VA mental health facilities might differ from general population mental health facilities. I know your study strictly looked at the VA, so you don't have direct comparisons in there, but if you have any insights that you've gleaned from the literature or from your experience.
Well, I think this is where the VA mental health guides were very helpful. Again, they were a great resource for best practices because they specifically focus on veteran populations. I think there's a saying in the VA that if you've seen one VA, you've seen one VA, and so it's something that we definitely try to approach the information that we glean from all these quality improvement efforts as distinct. I know that there are certain VAs in the study that had a large population of veterans with substance abuse issues. Those differ from veterans who might be in the same space often, who are there for geriatric psychiatry reasons. And so in my experience in working with other mental health environments, you don't often have that broad continuum of diagnoses in the same space in the way you do in the VA, where it's all veterans, but it's veterans from various different conflicts. It's veterans who are struggling with various different either behavioral-based, like substance abuse, or mental health-based, such as PTSD or geriatric psychology issues. And so that in and of itself, just again, anecdotally from a professional standpoint, is a little bit unique. But again, I'll just say that's where the VA mental health design guides were very good for us, making sure that we were speaking in contextually appropriate manners and guiding the research according to what they know best about that particular care paradigm. Sheela, would you have anything to add to that?
Well, just that, currently I would say the veteran population is much more heavily male than female. So I think that's the difference from the general population. And also there are just interesting things that came up. I remember someone in one of the interviews saying that it's really important that these locks, these doors, the hardware on the doors is really important, because if it flicks a certain way, it sounds too much like, cocking a gun. Or there also seems to be, veterans don't want to have their back to the door. So the placement of the bed and having, good visibility to who's coming into that room. So there are some things that I think may be unique, but I believe generally the strategies for veterans would be very, applicable in the general population as well.
There's a great question earlier, which I think we should probably just add to all of these and ask the researchers for every journal club meeting, which is, what were the biggest challenges in this study?
Do you want to take that?
Oh, goodness.
Like me?
Well, I'll just say I have so much tremendous respect for the VA. Like any big system, sometimes things just might move a little slowly sometimes. So that is certainly something to consider when doing work with, I would say, probably any large governmental agency. But I got to say, the folks that we work with were just so helpful and so excited about the work that they were doing, and it just it made it really interesting and a really good project. But Lisa, you can probably add to that.
No, I mean, I would agree. I'd say the biggest challenges were access and continuity. Again, I will absolutely reiterate what Sheela said in terms of the champions at the VAs that we worked with were phenomenal, and they were so willing to jump through so many hoops to get us access and be able to get us into different interviews and arrange different interviews. I'm so grateful to Tennessee Valley, VA New Jersey, and VA Ann Arbor for giving us the access. But it is very challenging. There are barriers to being able to do research.
Sheela, you made a really interesting point earlier about engagement and purposeful disengagement. Can you talk a little bit more about that and what it looked like in your experience of this study?
Sure. Well, sometimes it is very simple interior design strategies, right? So if you have wider than normal corridors with seating groups, where you can have, 2-3 people sit together and have a nice conversation, but these seating groups are far enough apart from one another that if somebody wants to be alone to read a book or have a private conversation or just reflect, then they can do that without doing anything really special, just wider corridors and nice seating groups spaced far apart. I think the other important thing, too, is, a lot of times you'll see that there's like one big day room and there's a TV in there and they'll do activities in there. Maybe they play cards or puzzles or whatever. And what we're seeing really is it seems much better to, instead of having one big room, is to have different and smaller rooms. So that maybe, some are for more quiet activities for people who do want to be alone and get away from their room versus, a louder, active kind of room. And again, I think this idea of allowing the veterans to be able to lock their doors and, not have people intrude upon them as long as they're, safe and they're doing well. I think there are a lot of real simple things we can do like that to allow people to have privacy while also encouraging, social engagement when people are ready to do that.
That really strikes me as, oh, sorry, go ahead.
I'm back now. I guess it cut me off.
Sorry about that.
No, that's fine. Because this is being talked about, that one of the things that wasn't really the area of study, but would be certainly an interesting companion effort to this regarding private areas, smaller areas for conversation. And this came up in the interviews, especially in one of the VAs that we talked to, was the importance of furniture. Furnishings are a big area of concern for a lot of veterans who are in these environments all day, every single day. And oftentimes the furnishings that are used in these open day rooms, which are also very loud, you've got a population that oftentimes, especially older veterans, are hearing impaired because there wasn't the noise protection. But the chairs are incredibly uncomfortable, and especially for those patients who are struggling with substance abuse, to sit in a chair that is not ergonomically conducive to comfort for long periods of time can actually exacerbate their need for pain controls, which is exactly the reason that they're in there to try to often get off of those. So that was another a companion insight into the private, more scalable areas with more comfortable furnishings in these environments.
That's a really great point. I mean, as a veteran myself, I can certainly testify that there are a lot of people out there with bad backs as a result of their service. And I imagine that would not be helpful to be in a really uncomfortable position all day long, every day. And speaking of which, thank you very much for this excellent research to help this population. I'm sorry, you were saying?
Well, thank you for your service.
I was going to say, if your bed is the only comfortable place for you to go, that's horrible. We don't want people staying in their bed all day, right? But if we don't give them comfortable furniture and spaces where they can go, without being bothered by other people, then, they're probably going to spend more time in bed.
Absolutely. I believe we're closing in on the top of the hour now. So we will move on to the thanks here. Thank you very much, Lisa and Sheela, for this interesting and thoughtful look into the potential influence that nurturing interior environments may have on patient well-being. This really important research for developing the kinds of testable frameworks that we're going to be able to use to make a real difference. This concludes our event. We will leave the webinar open for another 30 minutes so that you can download the EDAC and AIA CEU forms. Thank you again for joining us, and have a great day, everyone.